Okay. Okay, I already started the stream because if I have to share the screen later on, that's going to be complicated. So it's 5 now, so I will hide myself if it wants to work.
Are we ready, Linda? Are we ready with Nelsie? Shall we go with Nelsie first, or who are we going with first?
I have Nelsie's. Oh.
You have Nelsie, so she'll just tell you when she wants screen advance, slide advance.
Mm-hmm.
Okay.
Yeah. So I can launch. I'm gonna start the recording again, and I'll start the webinar. You'll see the numbers go up, and then you can go ahead and
do the
start.
welcome. Yep.
Yeah. All right. All right. Good luck.
We need.
Well, we would like to welcome everybody on behalf of the International Society of Pediatric Neurosurgery, the ISPN Education Committee, and the ISPN in general to this webinar. We have had a series of webinars on a number of topics, and we've been privileged to have leaders in the field throughout. And today is no exception. We have leaders in the field, thoughtful practitioners of pediatric neurosurgery, who are going to share thoughts and concepts related to pediatric traumatic brain injury. And we have folks from all over around the corners of the globe, including Jonathan Roth from Israel, Dave Adelson, who will co-moderate the session. He is from the United States, Nelsie Zanin from Sao Paulo, Brazil, and Tanak Pereira Pineda from Mexico City. And I believe it's Tanak's first time on the webinar, so a special welcome to him. And a special welcome to my co-moderator, Professor Adelson. Professor Adelson has been a leader in traumatic brain injury for a long time, and he and I have been friends and colleagues from the time he was at Pittsburgh to Los Angeles to a long period in Phoenix, and now he's heading the program in West Virginia, and he's had an illustrious career, and much of it has centered on concepts of traumatic brain injury. So I could not have been happier when he agreed to co-moderate. So, Dave, would you like to take over directing the session? And you and I will just go back and forth with questions and comments. Just before I turn over, I do want to encourage the listeners, please use the chat as you can for questions or for clarifications, because we seek to have this be as much of a two-way street as possible. Dave?
Thank you, Jeff, and appreciate the kind introduction. It always energizes me when we have such a wonderful panel with you today, really to give you perspectives from across the world and really try to provide some, what I would like to say, and I would probably echo Jeff's comments, is that I've been in traumatic brain injury work for a long time, and it's really over the last few years that we're seeing a real neat and exciting evolution in it. So I look forward to hearing the speakers as well as look forward to your questions and comments. And I guess we'll lead off with Professor Nelsie Zanin, and I'll turn it over to her.
Hi, everyone. Gratitude for this kind invitation, and congratulations, Jeffrey Blunt and Arthur da Cunha, for these education webinars and educational activities. And thanks, Linda, for sharing my screen, and we may continue. This overview is not individual work, it's a team work with medical students, the staff at home, that permits me to travel around the world. Please, Linda. Some words about prevention and what is mainly different on trauma in children's, non-accidental trauma, groin fracture, and ping-pong skull fracture. Next. Just an overview, the estimate number is around 1 million children death a year for preventable injuries, and trauma, morbidity, and mortality surpass all the major disease in children and young adults. And maybe we doesn't spend too much energy like leaders and try to work on prevention. For example, road traffic accidents are the leading cause in adolescent deaths. Next. And is the main cause of hospitalization. 75% is a mild trauma. But when we are talking about polytrauma or severe trauma, we have more mortality in in children than adult patients, probably related to disproportional of head size, the body, the thin skull, and open fontanelles. Next. Just to have an idea, the country where we have the road traffic mortality rate. Some countries, we don't have data. There is no reason for don't having data, but we know in low income countries it's very difficult to find this data. Even in Brazil, to separate by etiology is very difficult to find. Maybe the first step need to try to increase the registry with quality and the possibility to follow up these patients. Next. And the road traffic accident is related with the car speed and pedestrian accidents. The range can be to the 5 to 80% mortality on this group of patients. Next. And time to time, we forget to ask our patients with attention deficit and hyperactivity if they got or not previous head trauma, and is half of them with severe head trauma will have in the future psychiatric disease. Next. Just some pictures showing how we can try to have some preventions, easy to know in theory, but we see in several countries different practices on these seatbelts and helmets on the day-by-day lives. Next. Inside the hospital, maybe some questions to be aware. First is language communication. We need to have the team that give us the answer, the same answer with the scale to evaluate if it's severe, mild, or severe or mild severe trauma, to know what need to be do the next one. Next. Just the question about X-ray and CT scan. It's easily for us to put on guidelines. CT scan is better on frontal line, like a first exam, but depend where we are working. Just an example, the picture on the left is a CT scan on a private hospital in São Paulo. And on the right side, our friend, Dr. Monique from Canada, spent 10 years with us in São Paulo and now working in Mozambique, where it's very, very difficult to reach medical healthcare and more difficult to find a CT scan. Next one. Just one word, if you can read this paper on child's nervous system, is X-ray when start to be using in the medical field. It was in the World War I, just to identify metallic foreign bodies. Next. And still useful time to time for some special situation, like interparietal foramens, hypophosphatasy. Next. And to do the difference in the emergency room with osteogenesis imperfecta and non-accidental trauma is a very rare disease, but if we have several fractures on the baby, we need to think about this exceptional pathology before go ahead. Next. is exceptional, but we start using non-invasive intracranial pressure monitoring. It's available only in US, in Brazil at the moment, but when it was compared intracranial pressure monitoring and non-invasive, when we have P2, P1 more than 1.2, is more or less ICP more than 20 millimeters of mercury. Next. Just to have an idea, P1 is percussion waves, arterial pulsation, P2 is tidal wave, and P3 is the closure of aortic valve. And the normal is P1 bigger than P2 and P2 bigger than P3. Next. We are using in our outpatient clinics. Next. You can move, it's just a normal for demonstration waves. And his idea from this brilliant physicist, is not a physician, but on this 80 years old, start working on this project and show us that it's possible to have an idea what's going inside the skull, what's going on the brain for outside measure. Next. And we just published a case report. The big data is not showing up yet, but it's very useful to have an idea when you have doubt if the headache is related or not of intracranial hypertension. Next. Just one example for the non-accidental trauma, how we manage. Usually they came with subdural hematoma on different stage or different age of formation, usually are small babies below 6 months or below 1 year of life. With a tap, we can release the intracranial pressure at the first moment. Next. And they can develop hydrocephalus, like on this case, that it was shunted. And you can see the catheter on the temporal horn. Next. And sure, with neurodevelopment delay, and you can see the diastasis of the suture on this age, and the ventricle still big, beside the VP shunt working, probably secondary to brain damage. Next. And about non-accidental trauma, I recommend you to visit ISPN website. If you just tap Clash of Titans, you will be the giant on this topic, working and telling in the video YouTube. Is Matthew Vinchon from France and Dr. Tina Duhaime from US. They are brilliant on this discussion. I recommend to you, visit ISPN website, is for free. Next. And what we have done on this special topic, we work in not only physician, but lawyer, pediatrician, judge, policeman, try to create information and try to re-education on this special group of population. Not only punishment, but educate what can do to prevent the brain damage on this group. Next, please. And the question we perceive with this activity that was made when I was pediatric neurosurgical chair on the World Federation, we doesn't have monitoring this evaluation to have data before and after this course to see if we change something on the local behavior. Maybe we can try, like education, ISPN Education, to develop some metrics to see if we can change something before and after this kind of intervention. Next. Next. Several approaches are done on this field, but we can demonstrate that to try to avoid neglect and child abuse is educate parents and provide some economical support when needed. Thank you. Next. Just a case in another topics is about growing fracture. This doesn't help in adult patients, it's usually in small age patients. On this 6-month-old boy, we have this skull fracture with some blood in the third ventricle. It was treated conservatively. And with time, we saw this diastatic fracture, probably linked to some tears in the dura mater and arachnoid adjacent to this fracture. Next. And the treatment is surgical one. Next. And on this small group of patients, we can do split bone like we do in the older patient. We try to manage, the main is try to close the dura in a watertight way and try to do a cranioplasty. The bone will try to cover this injury dura mater and try to give some place, next one, for extra place where the dura mater is normal one, because with time, usually you can have disclosure without need a secondary operation. Next. And pre and post of this case 10 months old. Next. In the third and last fracture that is only in the pediatric field is this kind of close depressed skull fracture or ping pong ball fracture. There is some papers on the literature, and we do a couple of times recently, that you can just do this kind of vacuum with the breast milk extractor and try to have this depressed skull fracture release without surgery. Next. There is other example in the literature. You can see you can reach a very good example without surgery. Next. It was 2007, old case. At that time, we treat with surgery. Some of colleagues still doing, is not complicated, is very simple fracture to treat. Next. This older case, at that time, it was more linked to X-ray, and can go next. And it was older case also, case 4 and 7, with conservative treatment. It's not too bad. At that time, show some literature linked that epilepsy wasn't linked for the impact time, but for the impact itself. And there is some series with conservative treatment at that time that was working well also. Next. In summary, trauma prevention is the key. Education is mandatory for prevent trauma. The data to follow the intervention on prevention is mandatory. A specialized center in pediatric trauma can improve the results and decrease mortality. Access to medical primary care is an issue in several different countries. Next. My mentors. Thank you. Next. And continue my mentors. Thank you very much. Next. And if you are not ISPN members, please, we need 2 letters, but if you don't have somebody near to you, you can send a letter to ISPN membership group or to myself. It will be a great pleasure to introduce you if you send to us the CV. Next. And I hope you can join us in Toronto for the next ISPN meeting. Thank you very much for listening.
Thank you, Nelsie. That's wonderful overview. And again, starting to introduce new technologies for something that is still what is the mainstay for what we measure in traumatic brain injury. Maybe we could go to the question thing, and there are a couple of questions in there. Should we take them now, Jeff? Is that where we should?
Yeah, I think that's a good time, Dave.
Okay, super. So our first question is from Dr. Azar Jatawa. Child with acute subdural with GCS of 15, fontanelle is open, and on the brain CT scan, it's relaxed. What will be the ideal management in this particular case? Surgical evacuation or conservative management with serial CT scans?
Very interesting question. I think the big difference is try to see if it's just a CSF fluid or subdural collection with blood. I think if we have, on the past, they call external hydrocephalus. Today is more acceptable benign subdural collection and subdural hematoma. If you have doubt, maybe we can tap with a small needle and try to analyze this CSF and be sure that is not consequence for a previous meningitis, not diagnosis or partially treated. Fontanelle tap, I think, can be a good start to have this difference for these three pathologies if you don't have the anamnesis that help you to do the right definition.
Yeah, I mean, I would agree. I think that it's what you're saying, I believe, with the fontanelle is it's sort of a intracranial pressure monitor, but we have to realize that a bulging fontanelle is an indication of ICP elevation, but a flat fontanelle doesn't rule that out. And a CT scan, there's many papers that show that it's not really the best way to assess that the brain is quote unquote relaxed. So I would be cautious. I think your exam is great if they're indeed a GCS of 15 and consolable and they have a subdural and maybe there is plus minus shift, then one can sort of decide on the need for surgical evacuation versus serial evaluation with CT scans.
I would echo what Dave just said too. It's the question opens so many issues that the GCS was an adult scale that gets carried over to children, like so much of the information we're going to talk about. That thanks to leaders like Dave and others on this call and in this community, we're beginning now to make inroads into it, that it's more than just adult scales carried over to children. So I have nothing to add to the suggested management, but it's a great opportunity to emphasize that point.
And I think that we would probably, and just going to Nelsie again, I think we would probably be much more aggressive in monitoring intracranial pressure if it weren't invasive. And so most of the decision-making is sort of on the, well, do we subject them to the risk of placement of a monitor? And so I think Nelsie has introduced at least some newer technology that's coming that could potentially be utilized for ICP management, even in mild or moderate cases. Would you agree, Nelsie?
Yes, thank you, David. Helps a lot. We have a limitation on this management that is movement. If the child have movement, we have many artifacts and we can be sure that the waves is real waves. But the advantage we have, we can repeat several times. It means if you have doubt, we can wait and see when the child is calm or sleeping, and we can redo this monitoring without being invasive. And answering the second question on the chat, yes, the ventriculomegaly in the first case can be a consequence for the brain atrophy. But when we treated this CSF collection with blood, the fontanelle became flat. And after this treatment, the fontanelle bulging again, and bulging with ventricle enlargement. and it wasn't treated only ventriculomegaly, it was clinical related manifestation. And at that time, it wasn't available non-invasive intracranial pressure monitoring to have this certitude. And we decided not to go to invasive monitoring, but treat already straight away VP shunt. I don't know if I answered both questions.
That's wonderful. And then we have another question. So what's your recommendation in management of ping pong fractures currently?
Good question. Good question. We treat the last 2 or 3 cases that was mild ping pong depressive skull fracture with this suction, and it was working very well. Not sure if the huge depressive skull fracture can work or not. Our last case it was mild depressed skull fracture, and I try to solve with non-surgical way. But if it doesn't work, you have every time the surgery available and you can do it.
Okay.
Let's move on to the next talk.
Questions? Yeah.
Yeah.
We'll now move on to Tanak Harada Pineda. Do we have your presentation up, Tanak?
Yes.
Just a word of greeting to Tanak. Tanak is a leader in pediatric neurosurgery. He's at Mexico City. He's a wonderful, experienced neurosurgeon who's been very gracious in sharing his time and his willingness. And I'm very grateful to have you here, Tanak. Welcome.
Thank you. Thank you, David. Thank you, Jeffrey, for the invitation to be here. And I'm Denoch from Mexico City. I am pediatric neurosurgeon in Mexico City. And I will talk about the compressive craniectomy for severe trauma brain injury in pediatric population. I work in the ABC hospital in Mexico City. Traumatic brain injury is the leading cause of morbidity and mortality in children. In addition, survivors may have cognitive and behavioral dysfunction. Many studies have demonstrated that high intracranial pressure is associated with increased mortality. In pediatric population, early decompressive craniectomy has demonstrated a potential benefit. And let me show you this case. This is a 15-year-old boy who fell skating and arrived to the emergency room in my hospital with this initial CT scan. You can see here it has an acute subdural hematoma, and he was with a GCS, a globus Common scale of 7. So the thing here is to decide whether to perform only intracranial pressure monitoring or to perform CT craniectomy, the compressive craniectomy in an early fashion. And as you can see here, beside the acute subdural hematoma here, we have also several intraparenchymatous hematomas in this site. So with this in mind, I will share some thoughts and we will go back to the resolution of this case. Severe TB is defined as a patient with at neurological examination with Glasgow Common scale of 8 or less, and we also have to take in account the mechanism of trauma, the associated injuries in other parts of the body, and the initial findings in the tomography, as I showed you before. Obliteration of basal cisterns is closely associated with intracranial hypertension, as I can show you in this case, with practically there is no subarachnoid space in any part of the tomography. So in this case, the associated intracranial hypertension is very clear. The initial management of this kind of patient should start with adequate ventilatory management, intensive care unit management, intracranial pressure monitoring in some cases, because I think that in some cases we should go for the decompressive craniectomy first and intracranial pressure monitoring. The indication for performing the compressive craniectomy are very clear. In this case, it's very clear that there is no need to be in only monitoring the intracranial pressure. We should do the decompressive to put an EVD and monitoring the pressure. So we have to take into account if the patient had a high velocity head trauma associated with CT findings, suggesting intracranial hypertension and rapid neurological deterioration. Intracranial pressure, this is another indication, higher than 20 millimeters of mercury for more than 30 minutes with no response to medical therapy should be an indication for decompressive craniectomy. And in this paper published by Professor Elbaba in 2020 and some other papers that are found, reduction of intracranial pressure allows for prompt disruption of the pathophysiology cascades that are disencadenated by an improved neurological outcomes. So this is the case I showed you before. The patient was submitted to a decompressive craniectomy. We put an EVD in order to monitor the intracranial pressure, and this is the craniectomy. The craniectomy should be extended to the floor of the middle fossa to release the pressure on the perimesencephalic systems. And it is necessary to perform a loose dural plasty in order to give space to the brain to enhance. And some authors only make the craniectomy without opening the dura mater. I think this is a mistake. In all cases, the dura mater should be opened, and sometimes it is not possible to perform the dural plasty, so we just put some Duragen over the brain because the condition of the patient does not permit, and we close the gallia and the skin in the usual fashion. In conclusion, the decompressive craniectomy performed early, less than 24 hours, or ultra early, according to the clinical condition of the patient and the history of trauma, are associated with better neurological outcomes. There are some use of an invasive monitor to measure the partial pressure of oxygen in the brain tissue that should also be considered as an indicator for performing decompressive craniectomy. However, in the plain trauma hospital, this is only a dream. We should work with what we have in hand, that is the clinic, the history of trauma, and the CT scan initially in order to take the decision. Thank you.
Thank you, Tanaka. I appreciate your commentary on decompressive craniectomy. I think, as most would agree, there's just not a lot of evidence in children. And while we have guidelines for the use of decompressive craniectomy, most times, unfortunately, it's based off of the adult literature and Peter Hutchinson's work and in a rescue ICP trial and things along those lines. And we tend to, I would agree with you that intracranial hypertension is what we're trying to avoid because it can lead to further cascade of events. It's just that we often say that, but we don't have a lot of data and in support. We know that it lowers ICP, but we don't know whether it really improves outcome. And unfortunately, I don't know other people's experience, but if things are looking poorly in the early period, sometimes there's a very nihilistic approach which is, oh, they're going to have a bad outcome, and so we'll withdraw care. So we really don't even know how many times these procedures and interventions help or hurt us. I think we'll probably see part of that in Dr. Blunt's presentation on gunshot wounds, because that's where we tend to be the most nihilistic, unfortunately, in these cases. But anyway, I'd like to open it up to questions or comments. Jeff or
one of the approaches that I've heard people talk about, and Dave, I don't think I've specifically talked with you about this, but one of the concerns is that people don't want to leave a vegetative survivor, right? That leave somebody who is alive but not back to, any interaction with family, any recognition or perception of self. And I think that's one of the biggest concerns that people have. And so I've talked with a number of people that have embraced the concept that the intracranial pressure from the first measurement is sky high, above 25, above 30, that's probably a situation that's not going to be undone with decompressive craniectomy. But if the initial readings are a bit more controlled, and one can make an argument that it's the secondary occurrence of the swelling and not the initial and primary brain injury, then maybe, so in other words, a situation where you have opening ICPs 15 to 25, because they're all somewhat elevated because of the trauma, that then escalate over the coming days to, 25, 30 or higher. Those have been good candidates in our hands. And then we try and just do a very wide decompression and always open the dura. Those are the cornerstones of therapy but at our center. But as you've alluded many times, this is not based on good quality medical evidence. This is experience, extrapolation from adults, and reasoning from what we think are the basics. Elsie's got her hand up, and I'm really keen to hear Jonathan and other comments from everybody. Elsie?
Congratulations, Tenoch, for the very wise decompressive cranectomy in children. Really, it's difficult to find the balance between preserve lives and keep the patient in vegetarian or vegetative states for long. I think the family consents and be honest with family, I think, is very important decision. But my question to you is about the bone. Did you keep the bone in the abdomen? Did you throw away? Did you have a bank to keep? Or is decision case by case?
Tenoch, I don't know if you could hear. Nelsie's question was what you do with bone. Do you keep the bone? Do you put the bone in the preperitoneum, or do you what do you do with bone if you do a decompression?
Oh, yes, I'm sorry, I was having a bad connection. No, we don't have a bank bones in our hospital, and I don't think there is any in Mexico. So we throw away the bone, and then we do a cranioplasty with several other materials. There is some practice that they put, some of my colleagues here in Mexico, they put the bone in the abdomen. But in some cases, I hear that when they took out the bone, it's reduced in size, and it's not able to be used again. So I personally usually put the bone away and then use some other materials to do the cranioplasty. Regarding what you say before about the outcomes, it is true. The literature is very controversial about whether the early decompressive craniectomy helps the patient. However, I think we should treat every case in an individual form, because we don't know what happened between the time of the accident and the time the patient arrived into the emergency room. What was the pre-hospitalary care, and what are the results? What can we do? And also we have to take in consideration the opinion of the father, because many times the father says, if my son is alive, I want the boy with me. I I don't care if he's in a vegetative state or not. And when you say, well, the possibilities of he remains in the vegetative state are high, they say, I don't care. And 6-8 months later, they come to you, look, my children is saying hi, and things like that. So I think we are obligated, I think, to individualize every case and do whatever is better for the child and the family.
I think Jonathan and then David both have hands up to make comments.
Thank you. There are a lot of question marks here, and you raised them, and I'm going to talk about some of them in my presentation. But talking about cranioplasty with some artificial substances, for small kids, not for 15-year-old. 15-year-old is like an adult for me. I mean, let's say for a 2-year-old, putting some artificial flap, obviously it will, within a few years, it will not grow. You know, how does the skull react to this foreign body? How does the skull regrow itself? I do not have any experience. I have one case, and actually the outcome was good, of a 2.5-year-old with a big craniectomy. But does any one of you have any experience with all these 3D models in very small kids?
So that was kind of alluding to where I was going with my question. So I think that there is a lot of work on cranioplasty, and clearly if you use the child's own bone, and you do it within a certain period of time after the craniectomy and you replace it, you'll have less likelihood of resorption. But once they have, for lack of a better word, have alternative revascularization in that area, it's very hard to put the bone back and get it to not resorb and get smaller, as Tanaka points out. And so we usually, similar to, and apropos to what you were mentioning, we do look at 3D reconstructions in order to try to create a model. And some of the like PEEK and other materials that are good for infiltrative bone growth and incorporation seem to do okay. Not as good as autograft, but it's the next best. Versus, do you end up with, a metal implant? But in the very young children, it's very, very difficult, and they oftentimes, you're still going to need to replace or reconfigure at a later time if they, as they grow, and if they get some level of deformity. I don't know what other people's experience is on this.
I would just comment that with the head size reaching the majority of adult size by about age 3, a 2-year-old, you don't have to have 100% coverage, right? A cranioplasty can have a margin where you don't have 100%. You'll leave a centimeter. That oftentimes will fill with a calcified scar tissue. But I agree with you that the incidence of complications and things like that is probably higher in those kids, but I don't have any data to support that. So that's great. Why don't is Jonathan the next talk on the agenda, Dave? Perfect. Dave, you're muted.
Jonathan is up next.
Perfect. So Jonathan, share with us if you would.
Yeah, I think I'm shared.
Yes.
Yeah, you can see me good.
Perfect. Yes.
So I'm going to be a bit practical and only a bit of papers. So I've listed up all the, I would say, nuances that I think are relevant for the pediatric group, especially the younger group, related to handling trauma, especially surgery related to trauma. So first of all, they have a low brain compliance caused by a higher relation of brain versus CSF as an adult. So I would say the safety margin for conservative treatment may be less wide, and you're going to have like a shooting up of ICP at a very fast point at some point at a very fast rate. So this is something that is, I would say, unique for small kids. They tend to have more Cushing's as opposed to elder patients. The blood volume is small. So obviously, every surgery, you need to take that into account. No one really knows what's a normal ICP in a kid. What is a kid? Is a kid a baby? Is a kid a toddler? Is a kid a 15-year-old? Obviously, these are all kids, but every one of them has a different normal range of ICP, and there's no agreement of what is the normal ICP and what should we be treating. Should we be focusing on an ICP, on the CPP, for how long? Obviously, in adults, there are a lot of questions, and in peds even more. Remember that the functional recovery in kids, well, some say it's better, some say it's less. I think it's better. You do see some plasticity, and kids with devastated injuries come out relatively less injured than what you would have thought. The prognosis of Glasgow 3 in kids, well, it seems to be that, I think Tenok said, or someone else said, that you do have some kids that come out of it with a good outcome. I'm going to show you a bit of literature. I would say my rule of thumbs are decompress early. Don't waste too much on conservative treatment. EVD, I found it as a very practical tool, and sometimes it will spare the need for a decompressive craniectomy. When you go for surgeries in babies, blood, that's the most important thing you should have in the room, even if it means that you wait another few minutes. Because once you open the bone, the kid is going to crush. The Cushing stabilizes him or elevates his blood pressure. You have to be ready to give him blood. How to decompress? Well, I'm going to show you a case that I had, and my take-home message from that case was that in small kids and babies, use the hinge craniotomy as opposed to an actual removing of the bone. We just spoke about cranioplasty. Well, the literature says that putting back the bone, you're going to have a higher rate of absorption compared to adults or to elder kids. And like David said, if you do put the bone, you should probably do it more soon than later. And remember that kids sometimes have a spontaneous ossification. Well, just like I would say craniosynostosis, you take out a big piece of bone sometimes, and it reossifies very fast. And you can see that sometimes after trauma. So don't be dogmatic, and I'm going to show you a case. And like we just discussed, there's limited experience with artificial 3D materials in children, especially in very small kids. So I really do not know what to recommend about that. Let's talk about the Glasgow 3 of these very injured kids. So in a few papers, with very low Glasgow 3 or 4 and pupil dilatation, there seems to be a very high rate of bad outcome, but yet you still have some patients with a favorable outcome, a Glasgow outcome scale of 4 or 5. So, and we don't know how to identify these kids in advance, obviously. So like others have just stated, we're going to lower their mortality on the expense of more injured children. However, some children will benefit from this, and we just do not know who. In another paper talking about the lower Glasgow of 8 and below, this table shows you the Glasgow, and you see Glasgow 3 with bilateral non-reactive pupils. Only 70% or so had an unfavorable outcome. Well, this means that about 30 had a favorable outcome. In another paper talking about Glasgow 3 with bilateral fixed and non-dilated pupils, there was about a 20% rate of patients with good outcomes. So just to tell you that don't give up just because the Glasgow is low and the pupils are dilated. Obviously, use your common sense, use the information seen on the CT, but don't be dogmatic. So this is a case of a 3-year-old that fell from the 2nd floor, had a right dilated pupil. She had a low Glasgow. We do not know. She was transferred from another hospital, ventilated. This is her scan. I hope it will show, just to show you. Well, I don't know who of you work with WhatsApp, but we tend to use WhatsApp very freely, especially vis-a-vis other hospitals. It's very practical, and I know that it's not very, I know the limitations, but just to show you here, this case, bilateral injuries, hyperdensities, etc. And she had a decompressive craniectomy. You see here a scan after some time. You see here the tissue loss. You see the big PMC, and you see the other changes. And eventually you see she had various CSF surgeries, a shunt, an endoscopy, whatever. And this is, you see the imaging. However, when you look at the child, well, this is what you see. So you see a very lively and happy kid. So I think it's very difficult for us to anticipate the correlation between the clinical outcome and the actual and the imaging. Talking about ICPs, well, there are not many papers discussing this. This is an relatively old paper from about 40 years ago, but nothing major has changed. It's quite sad to say. And you see here the norms that were given for various ages. Well, 3, 4 tours for babies, and 6 for children. These are funny numbers. 4 and 6 is exactly the same. So what is the norm? And obviously, no one really knows, and we still do not know. So this is another case that I learned a lot from. This was a newborn that had DIC related to a huge subacral hematoma, low hemoglobin, treated with whatever blood products, and he presented to us with the right-sided pupillary dilation. This is his imaging. You see the huge subacral hematoma. You see as a right subdural hematoma. Obviously, it's not all hyperdense because of the low hemoglobin, significant pressure signs, and because of the pupil dilatation, I took him for a decompressive craniectomy. So you see here the scan, a big decompressive craniectomy. I was very happy. The child made an excellent neurological recovery. However, this is a scan, an MRI after a few months, and you can see the brain herniating through the huge defect. I opened the dura. Everything looked very free, the brain looked relatively okay. But what's happening is a huge growing skull fracture through the dural opening. And think about it, that the craniectomy site is a site of least resistance compared to the rest of the skull. So what happens is that the brain that is growing is pushing itself out through the opening, and obviously the rest of the skull is going down while the other side is going up. So this patient had various plastic surgeries, etc. And this child is functional. He has hemisigns, but he's good. He learns in a regular class, and he's doing quite well. He should be now about 10, maybe more years old. Never had more surgeries since a shunt that was done not far after the original surgeries. So what I took from that at the beginning was to do the hinge craniotomy, which I think is a great technique, and you can find it on the internet, all different drawings and all different papers. But the basic idea is that you fixate the bone on one side and you enable it to float on the remaining sides, while you have to do something to avoid the bone from bulging, from going inward. So either put a plate or other technique so it doesn't go inside under the periphery of the craniotomy. However, I learned over time that there are other techniques, and I want to show you something that I learned from one of my ex-fellows, Danil. This is a small baby with an epidural hematoma. And what they did, you can see here, the hematoma is on the right. And what you can see an ultrasound probe on the left temporal region, while someone is aspirating the epidural from the right. And I want to show you how it looks. This is a hyperacute bleed. So you may think that it will not come. It's a 2 needle. I think it was a 16 or 18G. And you see, this is the epidural live while he's aspirating it. And you see it going down and disappearing. Obviously, it's a minimalistic procedure. And I think with guidance, it's a safe surgery. The post-op scan obviously looks great. The child is excellent, minimal procedure. And then I learned about his experience doing it for a subdural case. Also, a very small kid, a small baby. Sorry. Okay. So you see here a posterior fossa subdural hematoma that extends from the lateral side to the supracerebellar side, causing secondary hydrocephalus. So this child had a subdural aspiration, the same technique using the ultrasound, and this is a scan after 10 days. So there's no blood. The vents are still on the higher side. And this is 2 months after. And the vents have gone down. So just to show you that we should keep our minds open, and I would have never thought, I know that it has been published many years ago, maybe people have practical experience with this, but I've actually never seen it, and I would not have even thought about it, and my fellow showed me these 2 examples, which I think are very demonstrative. Like I said before, remember that spontaneous bone may formate in children, especially in infants, but even in elder kids. I have a 7-year-old that had spontaneous bone growth after a craniectomy. And like I said before, for that case, beware of growing skull fractures. So this is a 1-year-old that had a motor vehicle accident sitting on the parent's lap, came in with a low Glasgow, failed medical and EVD treatment. You see a very extensive injury, and eventually I took her for bilateral craniectomy. So what happened was that she came in a few months after. She's a very injured child. She has bilateral devastating injury, but she came in for cranioplasty, and what I saw that one side ossified, the other one was more or less the same as it was before, and both sides received exactly the same procedure. So I put the original bone back on the side where the bone was still missing, and did not touch the other side. And over time, you cannot tell what side was operated for bone replacement and what side had the spontaneous bone formation. So just beware, don't be dogmatic, and bone may reform after time. Now, one of the presentations before, you were talking about the yield of a secondary CT or follow-up CT, and this is a study from about 24 years ago from our center. Shlomi actually was involved in the study. 170 or so with moderate or severe head injuries, and these cases had ICPs, and they showed that there was no case where a routine second CT added any information when there was no other either raise in ICP or new neurological finding to suggest that there's any dynamics. So no CT actually changed the treatment. No follow-up CT. So, like stated before, we talked before about mild head injury, but here for moderate and severe, if you have an ICP and you follow the patient clinically, I think we can spare routine CTs. So that's it from my end, and thank you.
Thank you, Jonathan. That was wonderful, and I really enjoyed the case presentations. I think they probably bring up more discussion than anything else. We have a number of questions that are actually related to both yours and Tanak's talk. Would anybody in the panel agree that elevated ICP is an indicator for irreversible brain damage? And does the duration of the elevation matter? This came during Tanak's talk, so let you start first, and then Jonathan, I'd be interested in your thoughts on this as well.
Okay, I think we should not take for granted that initial elevated ICP guarantees disastrous results. I think we should take into account the clinic of the patient, the mechanic of the injury, and see how it responds to treatment. I think that's the rationality of my conduct. If we have a very high elevated initial intracranial pressure, I think we should go for the decompressive craniectomy, and from there start to see how things are going.
Jonathan, your thoughts?
No, I totally agree. You know, we all taught I think the major bulk of information comes from the adults, like you stated before, David. And eventually we all thought about preventing secondary damage. I don't have any more information, any more clever insights about this. And yes, I don't know what's the correct ICP, but I know that I don't want it to be high. So I still stick to the same numbers that, like you guys, and that paper that I showed about very low numbers as being a normal ICP. Well, use your common sense. In some cases you can solve the problem also with an EVD. I think decompressive craniectomy is a very good, efficient, but it's not a trivial procedure. It's not a difficult procedure. But if you can avoid it with an EVD, I think it's a bingo. An EVD I found has advantages, and I've seen a few cases that we avoided a craniectomy, and I think it saves additional issues for the kid.
Next question was, do you have any experience with multiple dural fenestration techniques instead of opening the dura and patching after bone removal? Jeff, you have your hand up?
Yeah, that's a topic that I've spent a little time talking to our residents about, and we have a technique now that we use that has really proven quite effective. And basically, if you think of your large craniectomy defect, and now you're looking at a tense dura, almost like a rectangle, what we'll do is we'll cut a series of slits from one corner to the other corner and not connect them. So you retain the capacity of the dura to stay closed. And those individual fenestrations of roughly 1 centimeter in length will enable you to get a sucker underneath the dura there, and you can very effectively, coming in flat and very parallel to the swollen surface, aspirate and even milk out, just with your fingertips on the dura, milk out a lot of clot. And I can typically get out more than 80% of the clot, 90% of the clot. Remember, in a subdural, you don't always want to get 100% of the clot because you're counting on the tamponading pressure to stop whatever bled in the first place, right? So I always tell the residents, don't reach to the midline, even though it's cool to get the blood out and get the color out and make the purple dura white again. Leave it alone. That little bit toward the midline is not what's hurting the patient. Get the blood out. And then, depending on your preferences, most of the time I open the dura. I'll lay a patch graft down, and then I get very low, and you can just take a scissors and just go between those individual slits, like cut, 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 and so the brain will start to swell out, at which point you drop your flap down and use some vertical mattress nylon, and you never get that fungating brain out that you get if you do a conventional curved opening around the edge of the dura like we do when we have controlled ICP. So that's a preference. I don't have data, but I've used it dozens and dozens of times, and I've never had the brain fungate out at me, and I've been able to get nice decompression. So I think the question is apropos. Multiple dural fenestrations, carefully done, can be a very useful technique.
Jonathan, your thoughts?
Yeah, well, it's interesting. When I started my residency, many years ago, then someone raised that option, and I actually built a model for that. And I totally agree that when you use it for subdurals, it's a great technique. However, if it's just for reduction of ICP and so-called to allow the dura to expand, then I haven't shown it in a mathematical, but I would say that my gut feeling is, I never published it, that it doesn't work. And we can discuss it. This is not the forum. It just doesn't work. And I have the explanation. So it's great when you have a subdural, but if you're doing it just for dural release and expansion, I don't think it has any value.
Okay.
You mean instead of opening the dura, Jonathan? Is that what you're saying? So that it just fenestrating without opening the dura, that doesn't do any good. I agree.
For what I did, I built, and I think it sounds like what you've been doing. It's like a circular but incomplete with fenestrations all around, and then you do it in a cone, like going towards the center in various and changing the angle. Never mind, it's I'm probably not really explaining it in a good way, but it doesn't really matter. The idea is that this potential loosening of the dura and enabling to expand, like if you do an FMD, an extradural FMD, it's a different thing because you have a thicker dura. For the cranial, for the supratentorium, I don't think it has any value. to do I would say a not full thickness opening, and to do a full thickness in these multiple cuts, it will not enable the dura to expand.
I agree.
Yeah. I always get leery of just doing the slits, and I tended to do them in line of my dural opening, because once you remove the subdural, then all of a sudden, if the brain starts to swell, and then what I ended up happening was the brain just coming through the slits. And so that's, and if you only do partial thickness, you're not really getting the subdural. So I'm interested in that further discussion. All righty. Next question was how to manage internal carotid artery stenosis and aneurysm. He had a case, this Mahmoud Ahmed, his question was he had a case greater than 75% internal carotid stenosis and an intracranial aneurysm that was greater than 7 millimeters. Would like to tackle that one. Well, I think stenosis is a challenge, and I guess if it's due to a dissection, that's probably a little bit different than if there was an underlying, let's say, older individual or even a young child who had almost like a moya type situation. You're still going to be worried about perfusion. And so if you have stenosis and an aneurysm, if it's a traumatic aneurysm, now I think that's a whole nother series of lectures on this channel. But that I think you're managing on a patient by patient basis, and now with endovascular therapies, I think, and or direct approaches, depends on the etiology, size, location, etc. Would others disagree? Okay. Go ahead, Jeff.
No, that was just professional stammering, Dave, because that's a challenging case, right? I think that's what we would all kind of struggle with that one. Again, what you said, I completely agree. Are we surmising this as a traumatic aneurysm? Are we surmising this is an aneurysm that already existed that we're finding in the setting of trauma? This to me would be a very challenging, thing that I would definitely go to endovascular people to talk through. But I acknowledge the difficulty with a proximal focal stenosis and the problem of dissection. Absolutely.
Okay.
So that's more stammering. How's that, Dave?
That was pretty good.
Stammering upon stammering.
Alrighty. The last question that we have for this speaker was, is bilateral decompressive craniectomy superior than bifrontal decompressive craniectomy to relieve intracranial hypertension? Jonathan, I think this was directed.
Well, the answer is.
Go ahead.
Well, the answer is it's for sure more efficient relating to the reduction of the ICP. By the way, another nuance that we didn't talk about, what to do with the middle bar to disconnect it or not. So what I would do is, if I do a bilateral, I would usually disconnect the bar in the anterior and posterior part and leave the floating part in the middle. But obviously not everyone does that. And yes or no to open the dura, I think Tanok talked about it. I usually do not open, but use your common sense. You put the hand on the dura, and if it's hard like a rock, then be more aggressive. Now, I think it also depends where's the injury. If it's a more diffuse injury, then I would do a bilateral hemicraniectomy. If it's or do the craniectomy much more backwards than as opposed to a more limited injury. But I generally think if you take the patient to surgery, just be aggressive. This is your chance. You don't want to go back there. You just want to do the job and finish with it.
Can't disagree.
Okay. Tanok, did you do you want to give your input on decompressive?
I agree with Jonathan, and I think that the objective of the decompressive craniotomy should be to relieve pressure on the brainstem, and first of all, and second of all, to enhance the venous drainage. That's why I think the idea of relieving the middle bar, it's very wise. However, not always we have the time because of the clinical condition of the patient does not allow it. But I think a very wide craniectomy to relieve all the veins in the cortical and to leave only the bar in the middle, it's and of course to relieve the pressure on the brain cell, that will be the main objective of the craniectomy.
Okay. Nelsie, did you want to comment your experience?
In our experience, I agree with your comments, Tenoch and Jonathan, but usually we perform bifrontal craniectomy or unilateral if the lesion is with midline deviation, but if is diffuse, usually we do bifrontal craniectomy, and contrary of the other version of Tenoch, we split the bone in 4 or 3 pieces. We put in a pre-peritoneal place, and a month or 2 months after when the child recover, our experience shows that even if we have some decrease on the bone size, is better than no bone at all in autologous cranioplasty afterwards. We don't have too much experience, but usually we do like that.
Okay. You know, I actually really like the bilateral frontal temporal decompression. I invariably do open the dura, and I just come very low through the superior sagittal sinus. I usually do a suture ligation and then carry it. When I do that, it's just amazing how much the brain relaxes. I particularly like it. And then when I took down the bicoronal incision, I preserved pericranium, and I just then, you let the dura reflect, and then you just basically roll the pericranium back over it and suture it right there. I've just found that to be really quite effective in sort of doing that. If it's a unilateral pathology, I would do a unilateral, but in looking at that, I've not really liked the bucket handle approach. I agree that it becomes more complex with new incisions. It's just, I think, just easier to do a generous bicoronal. We do those all the time when, we used to do, open, and still do open, sagittals or coronals. And I think that, everyone, including the junior residents, are adept at those incisions. You don't have to turn the patient. You can do them right on a Mayfield horseshoe or even a donut, depending on the urgency. And I like those if it's not unilateral pathology. Okay. Well, I don't see any other new questions in the chat, so we'll now move on to our next speaker, Dr. Blunt. Speak to us on penetrating.
Linda, do you mind putting my slides up? There we go. So if we can go to presentation mode, be ideal. Yep. So unlike Professor Adelson, I claim no specific, go back to the title if you would, Linda, one sec. I claim no specific academic expertise in this field. The hard reality is that if you're a practicing pediatric neurosurgeon in the United States right now, that the conditions there, not uniformly, but largely have forced us all to take on an increased knowledge and awareness of this problem. And it may be largely a focal geographic issue in our country, but it is a profound one. So next slide, please. So the beginnings of this describe basically a different type of problem. Cushing described penetrating injuries of the skull in World War I as one of the first really quality descriptive classifications of this, but there was nothing quantitative, there was nothing grade-like. And then in our world of pediatric neurosurgeon, the great Don Matson from Boston developed what I think is historically the first grading scale, where he established a 1 through 4 level with modifications of A, B, and C to indicate the progressive, quantifiable, or categorical, I should say, level of profound or progressively severe injury with relationship to the missile. Now, the missile itself is of modest significance in a modern series. Next, please. So marching up to the early part of the 20th century, much of the reported evidence, much of the reported experience was individual case series that oftentimes reflected societal issues, areas of regional conflict, areas of elevated combat and civilian military types of altercations had escalated levels of penetrating injury. And so you see from these sort of isolated series, what we had individual single digit to a dozen cases compounded with for things like stab wounds, pediatric plastic projectile types of wounds that reflected a limited experience due to a much more limited type of societal occurrence, right? The Memphis experience began to increase the numbers that we were starting to see. Memphis in the United States is a city that's plagued with a lot of violent crime, a lot of gangs and things like that. It was the beginning kind of the tide. Next, please. That we really began to see unfold as the 2010s became the 2020s, such that trauma, next please, trauma became the #1 source of death for children in the United States. And this was recently reported within the last year within the New England Journal. And you can see the broader context of our webinar today of traumatic injury is the #1 cause of death, and it's traumatic brain injury that causes half of those problems. Now, next, please. The sad thing is that the penetrating gunshot wounds of the skull and brain have continued to escalate within our culture and our society. You can see here the number of deaths. I won't read the slide to you, but it's staggering. Tens of thousands, 60,000 deaths, multiple etiologies, gunshot wounds now the #1 killer of all the traumatic brain injuries. And this is a tremendous public health challenge. Gunshot wounds in general and gunshot wounds of the head in children, just a catastrophic problem that virtually everyone in pediatric neurosurgery is seeing an increase in. Next, please. Such that the Surgeon General of the United States issued just recently, and in our country, this is a controversial issue because of the role and the privilege of gun ownership and the central role that is in our Constitution and some of the controversies that come from that. I'm not making any political statement here, just saying that many in our country hold that as a very important right. Others are very concerned by the impact of it in terms of the health. And you can see here, Dr. Vivek Murthy, firearm violence is an urgent public health crisis in the United States that has led to loss of life, unimaginable pain, and profound grief for far too many Americans. And in so doing, you would think this is an elementary type of conclusion to make, but this is actually a fairly brave thing to do because it will usher in has the potential to usher in a whole series of challenges, problems, and barriers for him to pursue this and for him to study this further. You can see there the economic burden is staggering, billions of dollars spent in medical care costs and in criminal follow-up costs, and the staggering loss of productivity to a workforce from gunshot wounds in our country. Next, please. So what do we know? Well, sadly, not a lot. We know a lot, or pardon me, we know most of what we know is extrapolated from adult literature, that penetrating gunshot wounds is rising. Unfortunately, it is significantly rising, and that assault, sadly, is a very significant cause. This is also an area of great disparities in terms of its impact. We talk about disparities being those qualities of medicine that disproportionately impact those of different socioeconomic standing, different color, different creed, different sexual orientation. These are medical outcomes that reflect those issues rather than issues related to biology, pathophysiology, or things of that nature. It's profound. 43% of penetrating gunshot wound injuries in North America are African Americans. And I probably should specify, not North America in general, because Canada doesn't share this problem. These are American statistics. When one considers that across the country, 12%, 12 to 13% is about the percentage of African Americans in the United States. Some parts of the United States, like the Deep South, have a higher population, maybe up to 25% African American. But when you see these statistics, 43% of African Americans are the victims of this. This is a profound disparity, and it should be a real target for our attention, both because it's the right thing to do and because we're committed to continuing to dissect and get rid of disparities. Again, it correlates with socioeconomic status. The mortality is very, very high, and the United States, unfortunately, shares a disproportionate, almost uniform experience with reported experience with penetrating gunshot wounds. Next, please. And this is a phenomenon that correlates, the profile of injury correlates with age. The babies, more often than not, almost uniformly, are victims of bystander, which is to say that an individual is firing at another individual, either targeting that person or at random in a shooting called a drive-by. The projectile strikes the child, sadly, sometimes coming through a wall, sleeping a child peacefully sleeping, playing, or resting in their, playing, resting, or sleeping in their own home, in their own bed. This is the young children. That as the kids get older, the more typical mechanism is that the weapon is found by a child at play, and either the child injures himself, or less commonly herself, or shoots a playmate. Finally, the two most deadly ones are the assault with intent and the suicide. And in the evolution of sort of some of the early papers on this, Mike Levy's series reflecting the large experience in Los Angeles, like the Memphis experience, these were the early sort of harbingers of what was to come. That one reflected 72% gang-related shootings. And when it was reviewed in an earlier cohort study, the same region, right, 1980 to 1987, only 34 children were encountered. 93 to 2000, I think it was 405 children. So you can see that it's consistent and the numbers going up. No, I'm sorry, that was 93 to 97. So the rate has gone up significantly. And there were none in that catchment community prior to 1980. So, I mean, it is very clear that this is a focal problem that is worsening, and it's related to a lot of societal challenges, at least the assaults. And then, of course, suicide. It's been said that if one attempts to commit suicide with use of a gun, there is a 90 to 95% chance of success. And if one uses a technique other than a gun, there's an only 5 to 10% rate of success. So the role of gunshot wounds to the head in children in the context of suicide, which sadly is also increasing, is significant. The profiles correlate with age. Next. So again, more of the same. Gunshot wound by intent and age. This ended, as you can see, assault and assault goes way, way up as teen years are entered, and the rate is 5 times in the U.S. what it is in other developed countries. Next. This basically shows the intent, gunshot wounds by intent over time. This ends in 14, and following that curve later, it goes up. Next, please. Not only does it show this phenomenon of penetrating gunshot wounds and suffering from gunshot wounds reflect age differences, there are times of the day and days of the week. It's probably not surprising that there is a peak both late at night and in the period after midnight until dawn, and that there's a peak on the weekend, right? So these are phenomenon of people coming together late at night, sometimes social, sometimes spurring altercations, sometimes spurring assault, and resulting in catastrophic, irreparable injury and endless suffering. Next. So what to do? We are trying to help, and we are trying to do what we can for these children and their families. Well, the fundamental principles are outlined here. The initial approach is immediate effort at life salvage. These, if they are severe injuries, and I should emphasize that there are many that are not, but if they are the severe injuries that indicate projectile deep penetration, the immediate life salvage is full attention. And that basically consists of control of any exsanguinating hemorrhage that's ongoing, which very often just involves wrapping in the acute trauma bay. 50% of people with acute deep penetrating gunshot wounds die at the scene. So those that make it to care oftentimes are still in extreme dire stress and require acute intervention to prevent them from acutely declining and succumbing in the trauma bay. That usually consists of wrapping and immediately getting control of the airway, breathing, and circulation here also refers to massive volumes of blood, as Jonathan was alluding earlier, and also control of coagulopathy. Then marching through it, patient stabilization, initial assessment, imaging, and then consideration of candidacy. And there's a flow to this. Next, we'll go through these a little bit more individually. So again, same concepts: external bleeding, the stability of the vital signs, the extent of the scalp and skull integrity. These are the things that one immediately looks at in the trauma bay. Is this a glancing injury? Is this an injury where the projectile bounced off of the skull, lacerated the scalp, and was a grazing injury? Or was this an injury that went in and caused a tremendous damage? And remember, the damage is not just from the projectile, but from the blast cone that is markedly, exponentially increased with a higher projectile velocity than with lower projectile. What about involvement of critical midline structures? Is the superior sagittal sinus in the pathway? Look, one checks immediately for entry and exit sites to look for vascular structures. Excuse me. And control of the exsanguinating hemorrhage is absolutely crucial. Compression immediately, followed by wrap and further compression. Once stabilization occurs, excuse me, then imaging and OR for consideration for exploration and critical care needs can ensue. Next, please. So this takes us to one of the few published papers that I think has really contributed to our more academic approach to this. The group at St. Louis, at Washington University, and St. Louis Children's Hospital, like others, presented an observational retrospective study of a significant number of patients that, while in and of itself probably wasn't statistically significant, it was a very strong paper in that they identified radiographic and clinical variables that they put together, next please, into a grading scale that enabled them to begin to categorically evaluate patients as far as their survival. And they made important observations that pertain to the finding of certain key landmarks. The presence of bilaterally fixed and dilated pupils for a penetrating injury had a 0% rate of survival long term. Initial ICPs greater than 30 similarly had a statistically significant rate of non-survival. Radiographically, those injuries that crossed both ventricles or involved a deep structure, such as the basal ganglia or other deep subcortical gray, crossed the third ventricle, or had 3 lobes involved, all were highly correlated with non-survival. Similarly, though, it also helped us on the more favorable side, because while it showed that 2/3 of the patients in the cohort passed, the survivors actually made a pretty good recovery. And these are probably your less severe injuries. So it is critical. This is a sort of a bimodal curve. The majority of patients with penetrating injury don't do well, but some can, and those with not less severe injuries, a high percent make a good recovery. Next, please. So this sort of summarizes what they came to, and they assigned points 3, 2, and 1 respectively for primary, secondary, and tertiary predictive criteria that are either clinical or radiographic. So you have it within the first 15 minutes. Once you get stability, you can get a CT and be able to have meaningful prognosis, right? And so they comment that with a validated scale, that they would consider medical therapy, in other words, non-operative therapy, for those with a score greater than 5. But they called for greater validation and examination in other cohorts and noted that this might make a contribution to prognosis and guidance of approach. Next. And then the group in New Orleans turned around and just recently, within the last 2 years, reported this observational retrospective series with an even larger cohort, where they basically used the St. Louis score and validated it in the largest cohort reported in a single institution at that time. And again, it shows the two curves at the bottom show that the majority of patients arrive with a very low GCS, and that only a limited number of patients in that particular cohort with penetrating gunshot wounds were treated with decompressive craniectomy. Again, the demographics very similar: 80% male, disproportionate share African American, and then the age profiles that we've alluded to in earlier slides. Next, please. So again, management details a little further down the line once we're outside of the acute trauma bay. There really aren't a lot right now. It's mainly based on experience in adults. It's mainly based on principles that we all seem to agree upon. We have nothing really granular or peer-reviewed as far as developing specific management details for penetrating gunshot wounds. Operative goals when one is considering operation is quite rarely does one intervene acutely, and it's typically a debridement and restoration and getting closure accomplished. Medical goals center on control of coagulopathy, control of ICP, nutrition, and infection prevention. Next, please. Same idea. Timing of surgery basically correlates inversely with severity. There's almost no role in a severe penetrating injury for acute, i.e. from the trauma bay, operative intervention. And the reason why is because the bleeding sources come from the blast cone. It is not the likelihood of encountering a single bleeding source, like in a trauma, like an epidural or even a subdural, and being able to control it, pack it off, and get rid of a clot approaches nil. And so as a result, the force cone is very wide. Sometimes the projectile or the blast cone shows a billiard ball phenomenon, where it can go and ricochet off the internal table. And as such, the potential for recognition and control of a single bleeding source is essentially nil. So the notion early of surgical intervention for a severe injury is a non-entity. If it's severe, compression, wrap, control, battle coagulopathy, examine, and image. That's your pathway for your severe gunshot wounds. Now, the minor ones, skull, scalp fracture, Operative intervention may be much earlier, rarely acutely from the trauma bay. Usually it's an issue of trying to control ongoing scalp bleeding, deal with any down-driven fragments, reduce risk of infection, things like that. And again, the primary issues for operative treatment of penetrating injury typically is debridement and closure. And I only put reconstruction in there in the setting of the minor injuries. Next, please. Subacute management, again, this gets into fairly common stuff. Control of ICP. I embrace Jonathan's concept of a role for EVD. You'll probably save more lives putting in EVDs and taking out pus and blood than all the rest of everything else we do. EVDs are central. If they're in a terrible state with very elevated St. Louis scores or fixed and dilated, sometimes an EVD is not pursued. We've talked a little bit about decompression, and I won't go into that further. Maintenance of critical cornerstones. Coagulopathy prevails in these patients, and you got to stay right on it. It can come later. Prevent the coagulopathy that can worsen the problem. Seizure prophylaxis, infection. And then you get into this issue, excuse me, next slide, of dressing changes, because this can be a real challenge. And we've had a real issue with this of what do you do with situations where you have patients who have very severe prognosis, very profound injuries, just a whiff of neurologic function left, but are still lingering and are now going into many days of management, or even things like hygiene and basics of cleanliness and things like that, predicated on pressure dressings applied in the trauma bay come to play. These are very difficult issues. We don't have guidelines. When should the dressings be changed? Should we be doing this all in the operating room? What about our nurses and our critical care teams that are in that space, in that environment? What about the families that want to know that their loved one is getting the best available care? And sometimes we're struggling with things as central as hygiene and cleanliness of the dressings that we've applied, but full well knowing how incredibly acute the situation was when those dressings were applied. So these are very, very difficult issues. We have very limited guidelines and experience on which to go. So this remains a very challenging area. And we have to keep very attuned to our people and to our helpers. Next, please. There still remains some encouraging factors, though. And many of these injuries that we always get very focused on the horrible ones, but some of these injuries are low velocity. Some of these injuries are air gun injuries. They can be significant, but many of these injuries, thankfully, are grazing injuries, right? And the grazing injuries don't have as severe of a prognosis. And children do show a higher rehabilitation potential. And just as Jonathan showed us with a couple of the cases that he had, some people that we think that aren't going to do well end up doing better. I was one of my early cases of penetrating gunshot wound was a murder-suicide in which the children were all shot by an adult in the forehead, and it went across and came out on the other side. And I'll never forget that evening, because I thought, oh goodness, all three of these kids are going to be, are not survivors, and they all survived. Now, bifrontal injury is a serious injury. The potential for loss of executive capacity and disinhibition, that's significant. However, many of these kids have a high rehab potential. These lower velocity injuries can do okay. Next, please. And this was just to make that point about the increasing incidence of these lower projectile injuries. And these weapons are quite common. They're not intended for hunting. They're just recreation. Sometimes they're romanticized, but these can end up in intracranial injuries as well. Next, please. So in the United States, where do we stand on this? Well, they surveyed neurosurgeons, and it's this is a mixed and challenging field, right? It depends entirely on one's perspective as far as what the conclusions that are drawn. Only 20% of almost 8,000 AANS members who were approached to answer this survey responded. A number of them fired weapons in the last year, so that weapon ownership, as you can see there, almost half own a weapon within their home, and and many have actively involved in either hunting activities or target shooting or home protection. Next, please. And without diving too deep into the granularity of this, the overly busy graph on the right shows the A and B broadly the types of approaches that people would have to trying to make these approaches to decrease these rates. The ones on the top are more proactive, and the ones on the bottom are a little less proactive. And the diagram on the left shows by specialty and by year of training, kind of how people sorted out with regard to their opinions. So there's general consensus that something needs to be done, but there's anything but specifics on exactly what the appropriate steps to take are. Next, please. And with that, I'll conclude with gratitude to talk here and to participate in this great forum with so many other speakers under Dave Adelson's direction. Thanks very much.
Thank you, Jeff. That was great. I just want to caution, that when you look at the statistics, for example, the New Orleans study, there were 80 patients that they reported, only 20 of them got ICP monitors. So in some ways, they were being fairly, and we talked about this earlier, about being nihilistic. So if you've already made the decision the patient it's non-survivable, then you don't do therapy in order for them to survive. And so we have to be cautious in determining that someone is non-survivable, because apropos to Tanak's presentation and Jonathan's, there are many survivors when they look horrible in the early period, and that's the great thing about children. I would also say that children tend to diverge. If they're not going to survive, or they're going to have a very poor vegetative outcome, they don't survive in a vegetative state. I would say on less than one hand that I've seen vegetative children. Now, neurologically devastated, absolutely. But in a sense of we have to be careful about making decisions in the early period after an injury, being able to define what their long-term outcome is. And so while I think those studies are great observational studies, they're an observation of our present management of what we consider non-survival.
I agree, Dave. Can I turn it back to you, Dave, because you've thought about these things a lot. Do you see a path forward? The one area I thought about is that maybe where we can find common ground is the securing of weapons and things like that. But those age ones, the assault one's going to be difficult, right? Because that goes to such difficult things that are happening within our society. But maybe people on various sides of this issue can come together for better control of weapons in households to prevent those younger children that find weapons and shoot themselves or shoot a playmate. What are your thoughts? Does the Surgeon General's statement, is that going to move the needle, or is that just going to be another sort of flash in the pan here?
Well, in order not to totally insult our international colleagues now talking about U.S. politics.
Yeah,
but,
right, exactly.
It's a states' rights thing, and I will tell you a funny statistic, two funny statistics. One is that I now live in a state here in the United States, West Virginia, that has the highest per capita guns than any other state in the United States. But interestingly enough, it has the second lowest violent crime statistic in the United States. So guns and violence are not necessarily correlated. What you have are societal norms, and again, it's the sensationalism has led to further sensationalism, and I do have some issue with it. Now, relative to should we make it more difficult for children to have access to guns, absolutely, as we should also limit our those with mental illnesses and histories of violence, that those should be much more difficult for them to have access to guns. But for those who are utilizing them for hunting or for sport or for other things, I think, that becomes the fine line. Nelson, you have your hand up. Go for it.
Thank you very much. Wise discussion and excellent presentation, Jeffrey.
Excellent. Yes.
I will start with your comments, David. I agree totally. It is not a question the most you have guns, more you have violence in your country, in your region. Is the opposite. Is a narrative that somebody are trying to tell to the humanity. Is not true at all. The totalitarian countries, the first step is try to eliminate the guns from the human being, because you are not anymore able to fight for yourself, for your family, for those that you care about. I agree with you, Jeffrey. Maybe we need to educate people, try to protect the children to have less access to the guns, because they are not aware how they can blame others or harm yourself and friends. But something caught my attention on your initial data, Jeffrey. 20% suicide, children around 10, 14 years old. As a society, morally, maybe we are doing something wrong. We are not putting light or hope for the future for these children. How we can imagine that a child 10, 14 years old kill himself or herself? Maybe we are not doing the good lesson at family, like at school or human being. Maybe we need to think about is not eliminate the guns that we can solve the problem. Maybe we can try to put lights on what we are doing, what we are teaching, how we are dealing with our troubles, because the children learn more by experience than theory. They are seeing something, they are listening something that encourage them to kill themselves. Maybe we can try to get a filter to see what we are trying to teach these children. And one more last comment, Jeffrey. When you tell us that 90% of the world reported experience with gun is from United States, is understandable, because most of the countries don't have data.
That's absolutely right.
If you have data, you can deal with. Usually, we have the data behind the carpet. Just for you to have an idea, in our country, we have 40,000 violent deaths a year. But we can't see these reports on the media, we can't see these reports on the papers, because maybe we are ashamed. But less than 10% of the violent deaths are clarified. It's our state, dear.
Yep, it's a great point. It's a really
great point. Yes.
Yeah, about the importance of data. I mean, if there's going to be advocacy, it has to begin with data. And the hard part is, in countries of very limited resources, it's hard to make the case. Somebody has to pay for that acute upfront cost of compiling data. And in a hard-fought environment, someone says, well, what are you going to get for compiling the data? And the answer is, you're going to get better answers down line, but people want immediate returns. And it's a challenge. So that it's, we see it in here. And another area I'm interested in of advocacy for nutrition, we say, well, the worst area is this country, but we know it's not, because other countries don't have the data. And we know that the incidence of these problems is worse in countries that don't have the data. So for those who are listening, who have any impact in these things, there is tremendous value in starting to collect data. Data, well collected, properly compiled data, is the beginning of moving this problem. And while penetrating injuries may not be a problem specifically in your country at the same level as it is in my country, road traffic accidents are ubiquitous throughout the world and are massive contributors to children's death and suffering. And it's an area where we can all improve, including the United States. And we need to continue to get data and improve our data and look at our data to continue that process. All of these issues bring us to social and societal issues as much as neurosurgical ones.
I would agree. I think, we have very, very skewed view towards trauma sometimes and other areas because of, the data that comes out of different countries. And I think as we enlighten people as to the issues and the problems, I think this is a great opportunity for us to move forward in these different areas. So I would absolutely agree.
Yeah, Dave, there's three
Yeah.
quick questions. I'm going to just touch
Exactly.
on them really quickly because
Go
I
for
don't care about my thoughts as much as I want to hear everybody else's.
That's a good
Current
thought,
approaches
John.
to gunshot wounds to aerial firing. I'm presuming that's when the weapon is fired in the air and the projectile goes very high and comes back. I don't think that the mechanism impacts our approach so much. And I may just be reflecting my ignorance here. That is an uncommon mechanism in the United States compared to other areas where the discharge of weapons is a common celebration technique. That's less common in the U.S. So we see a relatively small number of those. And then the second question is decompressive craniectomy on multiple lobe injuries. That to me, again, comes late. I don't think it plays a role, but I'm going to stop there and see what others think on those two questions. Aerial injuries and decompressive craniectomy in multiple lobes. Dave or Tanak or anybody else, please.
Tanak, why don't you tackle it? Do you use decompressive craniectomy, multi-lobe injury in a child? You're muted.
No, I only perform craniectomy for bilateral, normally frontoparieto-temporal, and not for multiple focal wounds or hematomas. I don't think that will work. I think, as I tell you before, the objective of the decompressive craniectomy should be to release pressure over the brainstem and enhance the venous drainage to restore the intracranial pressure. That I think that's the objective. And regarding the aerial shot wounds, I have only two anecdotal cases in which the patient was in a party in his town, and they fell apart because somebody shot to the air. And these were very, very benign wounds. If the patient went to the emergency room, he was with the Glasgow 15. He was observed. We did not do anything to the wound. It was an occipital bullet. And after 3 months, the bullet migrated to the spinal canal in the cervical spine. And that's where the patient started to complain of numbness in the arms, and we perform a laminectomy and take out the bullet. That's my experience with that kind of bullet.
Wow. Yeah, Jonathan, I'm interested. I think Shlomi kind of talked about it during, with gunshot wound, limited debridement, really mostly just closing, open wound, and not doing necessarily a large decompression and debridement. Has that been your experience as well?
Yeah. Well, the main literature comes from shrapnels and not from bullets. And generally speaking, shrapnels, I mean, every case is obviously a whole story by itself. But generally speaking, you do not need to run after the shrapnels. I have a series, Jeff, you showed that these round things, we call them ball bearings. So we had some some part of all different suicide events that were some years ago, and they were like packed in the bombs, and people had these injuries to the brain. And it's interesting, I wrote a series in JNS about that in adults. They have a certain ballistics that is unique because they're round. So they have less collateral damage than all these irregular shrapnels and, you know, the more pointed bullets. So sometimes you can have very limited injury when these things go. I had a case with the cavernous sinus and other things. And like I said, you do not need to run after these things. It has been shown that running after these bullets / shrapnels does not decrease the rate of epilepsy, does not decrease the rate of infection. If there is a problem, then treat it. If there's no problem, you do not need to run after them. I was not regarding that question about decompressive craniectomy. Well, I'm not sure if what I'm saying is correct or not. It just seems to me common sense, but I think gunshot wounds, if the patient is not severely injured, I mean, if he's not devastated, that would probably be more correct.
Yes.
Then probably it's more focal injury as opposed to blunt head injury. And in blunt head injury, you do a hemicraniectomy or bilateral craniectomies, whatever, for more diffuse problem. In gunshot and all these shrapnels, you have a more of a focal damage. If it's not a devastated case, it becomes more of a focal damage. And I don't know if my gut feeling tells me that decompressive craniectomy, if there's a multilobar, actually it does sound logical if there is high pressure. So, you know, obviously every case is tailored.
Jonathan, on your service at any time, or in a month, how often will you see a penetrating injury?
Very rarely, you know, over the
Very rarely.
October 7th, we had obviously some civilians, but
Yeah, sure.
it's very rare, very rare.
Yes.
Thank God, you know, all this talk that you gave about the United States, no, we don't have that.
Yes. Yep.
Yeah.
And as Dave alluded, it's complicated in the United States. You can't just say that higher guns correlate to higher, because what's happening is there are focal areas, sadly, increasingly more and more of them, where there's inherent problems, right? Inherent problems within many of our cities, and then guns become the method by which some of those conflicts get worked out between gangs, and the gangs reflect a lack of what Nelsie was talking about: nurturance, support, membership, acknowledging and building people up to feel good about themselves. These kids find that in the gangs that they don't find in families and other social structures, churches, families, schools. So they find it in the gangs, and the gangs fight each other, and they use weapons. And these are terrible things, violent crime. So it's complicated. It's many faces.
Yeah. Access to weapons in the United States different than Brazil, different than
For sure.
Mexico. I mean,
Tanash, I'd be very interested. Tanash, what's your perspective? I mean, I know Mexico has violence in some areas, and some areas not so much violence. How often do you see penetrating injuries in Mexico City?
Well, I work in a private hospital, so the incidence it's very low.
Yes.
However, there are parts of the city in Mexico City, the orient of the city, where it's very frequent. And I have colleagues that they see every day it's a one shot because of gang fight.
Yes.
And some regions of the country, like the north and the Jalisco, Sinaloa.
Yes.
It's very frequent to have that kind of the wound, even in private hospitals. So in my part of my practice is not very frequent. It's very, I receive them from referred from other hospitals. When the patient has the possibility to translate from a public to a private hospital, I receive them, but it's not in an acute way.
Very good.
Yeah, I think if I may jump into this thing, I don't think the issue is guns. It's more of a cultural thing. And if we want to spare violent, not only gunshot, violent related injuries, I think we should be looking at things that have got to do with social media, with education. Guns are just a tool. Sometimes, like David said, you give this tool to people who have let's say, are not are in a certain culture and you have less injuries, and you give this tool to others and you have devastating consequences. But these others, these gangs, etc., we have the bad consequences whether they have a gun or not. And I think it's more of a, it's a social problem. It's not a neurosurgical problem. It's a social problem. We see it with our children, how much time everyone spends on these, excuse me, iPhones and whatever companies, all these social things.
Yeah.
And, I think the gunshot is just a consequence. We should think in a more broader way. We can discuss the ammunition, but it's well beyond.
Personal interaction, but also mental health and all of
that.
those.
Absolutely. So I am going to thank everybody. We're at the top of the hour. We've been together for 2 hours. Dave, I can't thank you enough. You brought gravitas to this and experience and across time and geography that I had hoped for. And for everybody else, it's been just all of the other speakers, it's been just great to hear perspectives from different corners of the world, different experiences, different approaches. And to the audience, I congratulate you. The questions were excellent. And we applaud and thank you all for participating in this effort. I want to extend Nelsie's invitation to everybody who's watching to join the ISPN. It's the largest and dare I say most influential of the pediatric neurosurgical organizations, because it's an umbrella for many of the local and regional societies with whom we have very close working relationships and partnerships. So please join, please participate, please join us again next month, and I'll leave whatever closure. Dave, any closing comments you might like to make?
Great comments. Look forward to seeing everybody in Toronto.
Very good. Thank you all very much. And Linda, if you'd be so kind as to close the link, we'll thank the faculty one more time. Bye, everybody.